Nice to see lots of familiar faces. Before I came to work for Health Education England, I did work in a family care division at one of our provider trusts. Nice to see some familiar faces. So firstly, I'll just explain a bit about who we are in terms of Health Education England and our links to some of the other work programmes, because looking through the agenda, we've got quite a few people here speaking today that link into various things. So we've got a national maternity team working across the country, a very, very small team, and then we link into the regions around the country. So I work as part of the North of England regional team, and we were hoping to have our Senior Responsible Officer here today, Ray Walker, so I'm really standing in Ray's place. It's kind of an equivalent to if you'd got a ticket for the new Spice Girls reunion. I'm probably more of a cheeky girl, so sorry about that, but hopefully I'll be able to cover Ray's slot okay for you. Because of that, we've got close links to NHSE and NHSI, and I'll cover some of that as I go throughout some of the detail. And we've also got links to what's happening on a very local level. So I'm actually in the ICS facing team for Lancashire and South Cumbria. So my level is really around programme support and programme inputs. I'm the workforce planning lead, so I'm working particularly around the continuity of care, a work stream that people will be working on. If I go back to the main slide, you'll notice that the project title is called Transforming, and I'm going to dwell on that a little bit later on and just explain why it's got that badge to it. But before we do, let's have a look at the why. So why we're trying to transform the workforce. Why can we not just do nothing? Everybody's busy enough as it is. Why can't we just plough on, keep our heads down and keep going? Well, most people will know, I'm sure in the room, that it's part of the NHS England review for the 5-year forward. There's an ambition back in 2015 around safety, reducing the number of stillbirths, etc. And then the Better Births document that came out in 2016. Since then, NHS England have been working on the programme, and there's 9 work streams, and the one that HEE are leading on is transforming the workforce work stream number 5. We're also supporting in other areas, specifically work stream 2 with NHSI, which is around good practice for safer care. Our strategy is due out either later this month or December, and what I'm covering today is very much the content of that strategy, so you can all feel really excited that you're ahead of the game and you've got some things already coming out so you can be in the know. And that strategy will really cover what we expect the demand for services and workforce to be and how that will help us implement the ambition in Better Births. So Better Births is the what, and say most people in the room will be familiar with the content of that. So if we look at some of the how really, so workforce transformation, it sounds really grand, really ambitious, but what does it actually mean? Well, it's about large-scale change. It's about things not changing incrementally, but in a large way. So it's about a cultural shift. It's about changing hearts and minds, about multi-professional working and training. There's very much a mantra now that if teams work together in reality on the shop floor, then they need to be training together as well so that they've all got that shared perspective of the roles that people within the team play. It's around upskilling, talent management and innovation. So it's about people working to the very top of their licence and indeed having extended roles. So it's really a lot around harnessing that talent and giving people the opportunity to really make a contribution. So lots of talk around flexibility in terms of maybe staff on Monday working in one area, one setting for one provider, and maybe by Wednesday if they're working somewhere else, looks totally different. So it sounds really grand, but what will that actually look like and how will we know when it's done? And there might be people who feel that it just isn't possible. So I'm just wondering, is the link on the next page? Let's have a look. Yeah. So what I thought might be useful is just to get you in the headspace about what might look different is a 3-minute YouTube video. You've got lots of work to do today, so I thought you could have 3 minutes of YouTube. You can pretend to be a teenager. Vanessa said it was okay to have some fun. So this is around the challenge. You've been given the challenge around Better Births, but equally if I said to you, why don't we remove all cars from British cities? just get rid of them, how would that look like? That would solve the obesity problem and it would solve pollution. So why don't we do that? So let's just jump into another world for 3.5 minutes. It's called Groningen, the world's first cycling city.
Groningen.
Oh, thank you. Say it again, Renika.
Groningen.
That's much better, isn't it? So yeah, just YouTube it. So I think it's been a cycling city since the 1970s or something, which sounds unbelievable. You'll notice that they've got the things for carrying items as well, and apparently anything that's smaller than a fridge, they have to transport by bike. So I'm just thinking of the usual excuses of why, we can't do this because we've got to move heavy items, we need a car for this, we need a car for that. And it really sort of challenges everything around that. They've got places to leave the bikes and then they just borrow a bike, and it's just a totally different concept. So hopefully something just to stick in your mind. So the new workforce is meant to support new models of care. So if you're all busy, the people in the room responsible for shaping and designing services and models of care, if you're all really busy designing the most innovative, different services, unless you've got the workforce right, and the right workforce with the right numbers, right skills, and not to be overlooked, the right values and behaviours, unless you've got that right, it doesn't matter how good your new model of care is. I don't know if anyone's familiar with this and knows what that is. And we should have done the poll thing. Can you vote and tell me what it is you can see? Anyone know what it is, that building, that institution? Thank you. A fiver for you. It's a nursery. I don't know where it is. I've forgotten where it is. Do you know where it is?
I think it's somewhere in Asia, isn't it?
Thank you. So it's a nursery. So there's trees growing through the building. There's children running along the roof, the donut-shaped roof. There was no walls, there's no doors. So again, it's a really totally different concept. Certainly the nurseries I know, where I collected my child from once, didn't look anything like this. So it's just that reminder that even if, from the services that we see now, even if you change and you develop your donuts, unless you've got the workforce to deliver them, it doesn't matter how amazing they are. So back to the strategy. So there's lots of key principles that you'll see really woven through the strategy when it comes out. I'm not going to go through them all. They'll be really familiar to you about the right suppliers, staff, looking at your current workforce, looking at differences. What you'll be really wanting to know about is the chunks really, and the key areas of focus and the workforce groups. So can we just have a check that do we have somebody from each of those areas within the room? Have we got any midwives here? Brilliant. Have we got any support workers here? Any neonatal nurses? Hey. Any medical workforce? Yay! Sonographers. Oh, I was really hoping we did. Never mind, we'll come on to sonography a bit later on. I'm going to go through this quite quickly. There's a lot of detail to share. If anyone wants to slow me down, ask me questions, or just pause, please do let me know rather than let me rush through, or indeed we can pick up later on. So the first sort of chunk of the strategy, as you would expect, around midwives. Huge amounts of work going on in various work programs around capacity, training placements, retention rates, transition from training, the actual curriculum itself, working with partners, return to practice, and lots of stuff around clinical leadership. Maternity support workers, again, I know that our LMS are really heavily involved in this project, and it's really around further developing and really professionalising the role, so looking at key standards for consistency and rigour. Birth Rate Plus recommends a 90 to 10% split between qualified and unqualified workforce. And for Lancashire and South Cumbria, we've already captured that data, and some of our providers even improve on that and have made more use of the support worker roles, and some of them have a little way to go that aren't quite there yet, so lots of further learning to be done. And also next year some work around a higher level support role starts, which will be interesting to see how we can take that forward. Very busy slide, apologies for that, for our neonatal nurses in the room. Again, lots and lots of different work around transforming, around curriculum, some interesting stuff around family integrated care models, going back to the interdependencies that Vanessa mentioned of not looking at one workforce group without another. Again, stuff around curriculum, extra training, multi-professional working. Specifically for the medical workforce, again, around attrition, developing SAS doctor roles, actually looking at the model for the consultant role. The strategy recommends drilling down and looking at subspecialisation. Again, in Lancashire and South Cumbria, we've already captured that information, and we know that out of the 53 consultants across the patch, 6 or more, one of our trusts didn't give that breakdown, but 6 or more don't contribute to obstetrics. So we already understand the sort of subspecialisation and can have another look at that. And again, trying to boost further training to the work stream up until 2021. Sonography has been a real challenge, and there's been some particular short-term sort of injections of capacity. So next year, 241 sonographers will be out-turned into the system. I've tried to find what we've got locally, and I think it's around 30. In our local universities, we may see around 30 qualify next year. So I would say to people in services, are we ready to grab some of that additional workforce? If you've got challenges in that area, you probably have. Are you ready to because everybody will be competing, and we can drill down into more of that later if that's of interest. Longer term, HEE are looking at a direct entry route and also increasing the pipeline, but nothing will be outturned before 2021. So that sort of immediate action is the one to be thinking about if you've got immediate challenges. So as well as those 5 chunks of the strategy, you've then got lots of stuff around the softer, more fluffy sort of areas, shall we say. So lots around leadership and safety, leadership development. Lots around culture and productivity. And around workforce planning. As a workforce planner, I would say what I'm about to say, but again, we're ahead of the game with workforce planning. We commissioned a piece of work to start off the project to really look at understanding our current workforce, and we've got Kendall Bluck here with us today down at the front, if you can all wave. There they are. So yeah, it's not work that I've done. Our partners have helped to really get some of that key data. We're still waiting for some of those returns. So if you're sat in teams where you've had an email from Kendall Bluck about giving some figures and you've not managed to do it, if you can provide that, it's still really, really useful, because we can really do some analysis then and look at and understand our challenges better. But there'll be more and more sort of work happening in terms of the planning side of things. Yeah, I'm going to just jog through there. So yeah, I've jogged through some because I want to spend time talking about some of the funding coming out, because I'm sure it'll prick people's ears up a little more. So there's quite a lot of stuff in the strategy around workforce development. And again, you'll have been doing lots of work in this area on various training programmes. One thing we've already done is the LMS have made a bid to the LWAB, the Local Workforce Action Board, and I think are about to get notified that bid has been successful, and that's going to carry on some of the training that originally was funded through the Maternity Safety Fund that I think closed, so that's helping us locally to carry that work forward. On Monday, the National Maternity Team are about to announce funding of £600,000 to help LMSs deliver continuity of care. They are going to ask for LMSs to bid for that money, and they've worked out it equates to around about £15,000 per LMS. However, if people don't bid for it, there'll be more available for others. So the name of this game is really getting ready, showing how you might be able to spend that money and move forward in your targets for delivery. So I don't know who it will be communicated to on Monday, but keep close to your emails. And in particular, there's going to be some kind of 2-day programme to deliver some education around that. Moving forward, once the strategy is released this month or next month, there's then going to be a bit of a reorganisation of programmes of work, and these will be more closely aligned with work with NHSE and I. So they are the chunks. So again, no surprises there. The medical workforce and the midwifery workforce are going to be co-chaired with NHSI for midwifery and for Royal College for medical workforce. The others are sort of more task and finish groups. They're already up and running, and I think you're heavily involved. So the maternity support worker and the neonatal one is about to be set up. And there is talk that might include paediatric nursing as well, going back to Vanessa's point about that scope and all the interdependencies, so that might broaden out. And there's going to be lots of oversight for the programme. The workforce development one has got some chunks in there that don't neatly fit elsewhere. So it's got the ultrasound, and it's got some training, and smoking cessation is going to sit in that chunk. And again, there's going to be funding announced of £150,000 nationally. And that is around sort of train the trainer programs. So I know that locally you're already on with some of that, and it might be that you can mobilise quite quickly and maybe to backfill some people to roll out some of that training across the system. So again, look out for that funding and make sure you've got the benefit of that. So I've talked really quick and jogged through lots of actions for the arm's length bodies, but also lots of actions for providers. So all the earlier stuff around retention programs, return to practice, yes, they're actions for us, but none of them can be implemented without the providers, because we can't return anybody to practice without practice, if you know what I mean. All of these actions and progress of the actions are going to be really heavily monitored. There's going to be programme management around the performance. So non-delivery is really not an option. There'll be detailed plans and things coming out. There's going to be a longer term piece of work after 2021, but the focus very much is on the here and now. So what are the take-home messages? Far too much to remember. You'll get the slide pack so you can go back and get some of the detail that I've glossed over. Lots of work happening. So I guess it's a pretty big elephant to eat, and you can only sort of eat it chunk by chunk. So I would say to think about what part can you play. So we've all got different hats, different roles within the room, whether we're patient, service users, service designers, healthcare professionals. What part can you play in the transformation? And when we talk about transformation, the reminder is, remember the alien. I didn't mention the alien. How did that happen? Oh dear. The alien, he was in there, I just didn't mention him. The alien, is the idea that if an alien lands within your service now and falls asleep for 5 years and then wakes up, that the service will be completely unrecognisable. That's the point of the alien. So yeah, remember the alien. Does your service look unrecognisable? Because if not, it's not transformed. If you've just tweaked it a little bit, but the alien still knows what it is, then it's not transformed. It's incremental change. Is your nursery donut shaped? So is your model of care very different? And does your city have more bicycles than cars? And that's why the alien's on a bicycle. And that's it. Questions, if we've got some. I don't know how I'm doing for time. Oh, not too bad.
A couple of questions, if people have got any. Monica?
Just a few practical questions, really. You talked about the qualified, unqualified ratio of 90-10 that Birth Rates recommends. Is that a recommendation as a top or minimum? Is it a maximum or minimum?
Good point. I don't actually know, so I shouldn't really guess, but I think
because it would be a concern if it's a maximum.
And there's the safety angle, isn't there, in terms of ratios and things. Yeah. I think there's lots of detail on it, and there's other sort of ratios as well. I think it's a rough guidance.
Does anybody know? I was going to say, does any of the head of midwifery know?
It's usual. It's the usual ratio of that, and we're all almost there. So that is what our workforce looks like now, very similar to that.
So it's not a maximum. It's you should have at least 10% of your workforce being.
You'd know your own requirements in your own provider trust, if we're looking at that, for example, to make that work. But we're all working with that now. That's not a new ratio.
Yeah. Sorry. Thank you. Thank you. And I guess you'll look at it sort of shift by shift in terms of safety, whereas it's more of a figure around that broad distribution of workforce.
That's how you map your workforce now.
Thank you.
That's how you look at it. Even though it might be different in different areas.
Yes.
I'm just concerned if that was sort of set as, oh, you have to have at least 90% qualified. That would limit the transformation you could do.
Yeah.
I agree, but and we're not going to get into a debate about Birth Rate Plus.
Sorry.
I'll be Matt. But I mean, I think if you look at the true, like Catherine said, workforce transformation, that is going to challenge quite a lot of the things that are out there at the moment from rural colleges across the board in terms of ratios, because you start looking at new roles, you know, not even talking about maternity, if you're looking at a stroke ward, you know, to me it's bonkers that you have to have 1 to 8 nursing staff on a stroke ward. Well, actually, the workforce you need on a stroke ward is far more therapists than nurses. So it's about having the right people to do the job, isn't it? So I think it is going to put into question some of the more of the traditional, like on the aliens landing now, that's what we look like, isn't it? But if they're 5 years, 10 years, it could look very different.
So thanks for clarifying, Renika.
I'm Anne Goodwin. I'm the co-chair of Pennine Lancashire MVP. Just bringing some context from outside of the medical profession that might be of interest. I'm an engineer, and our industry made a transformation, I'm going to guess 15 or so years ago, where we had a massive number of chartered engineers, which I'm guessing in this context are your experienced medical professionals and your experienced midwives, and we started to emphasise the role and the value of a technician in our industry. And I think when you're talking about upskilling and you're talking about the right person doing the right job and who does what best, it really resonated with me, that there was a time when almost technicians were perceived as being junior and reporting to the engineer. And that has actually transformed now to technicians actually being valued for what they contribute and chartered engineers being valued for what they contribute. And I think holding that model, it just really struck me that there's probably a role for that approach here, that your medical support workers could actually be valued differently from your midwifery team and your medical team.
Thank you. And that's where it comes back to the culture and the hearts and minds stuff. It's about that value, isn't it? We've got the roles, but it's about that value and that contribution, isn't it? It's a different contribution, but it's as valuable. It's not the hierarchy sort of thing.
The other thing, obviously, Catherine hasn't gone into, but there's an opportunity to talk about later today, is that if you think 5 years, 10 years, the opportunities for digital and technology are going to be massively different than they are now. It is moving at such a pace. There might be things that at the moment we are doing as a human being that actually there'll be a bit of kit that can do that far more efficiently, potentially, than we can now in 5, 10 years. So we really need to think savvy in terms of what we can use as those digital touch points, I think they're called, on the pathway. Ooh. To say, actually, somebody else or something else could do that piece of work for us. So there's lots of opportunities. Okay, thank you very much, Catherine.